Welcome everybody to this very special discussion that it's a privilege for me to be a part of. I have with me Diane Lee and Adam Meekins, and today we will be talking about the SIJ, the clinical reasoning process, assessment and management of such conditions, how it applies to people, and I'm keen to hear from both of them about their thoughts on this. So very excited to have you here. Thank you for joining us. Just by way of quick introduction, Diane, been a clinician for so many years, and I love what you've contributed to the profession. And you work in British Columbia, Canada. You've done research. You've taught others, including me, and you continue to work towards a better profession and building bridges. This all started with a post that Adam put up, and then you put up a post, and from that, this is what happened. So thank you very much for asking me to be a part of it. And Adam, I've met you in person too. I've taken your course on the shoulder. And massive social impact, social media impact, and just a way of cutting through and getting to the heart of certain messages. I was scrolling through your page recently, and I just loved some of these summaries. So fantastic. You work in the NHS as well as private practice. So fantastic to have the both of you on here. And yeah, I'm looking forward to a great discussion.
Well, thanks for facilitating this, Anthony. It's been a long time coming. I wanted to talk to Adam for a long time, and here we are.
Fantastic.
Yep. Thanks, Anthony.
No problems. So the way it'll work, just for the people that are watching, is that we've got some assumptions that we'll just put out there just as the basis of the discussion, and from that, we're going to talk about all of the processes. I will be putting the link to the different posts that we had been discussing. But basically, we've all agreed that everybody just wants to help people the best. And what we are actually discussing is how we do that from the research. There's lots of things about the research as well as the fact that people do have a preference for passive strategies, right or wrong, and what is our clinical reasoning process through that, about how that works, shared decision making. So, this professional discussion, it's going to be awesome. We're going to be talking about the evidence and personal experience and how that all mixes in together, and just how the research works. So just by way of starting this discussion, Diane, can I start with you? What would you define as an SIJ type of problem or condition or issue or dysfunction, or, there's many words there.
There are, and that language in itself is part of our problem, isn't it, in terms of communication. And I think what we've seen evolve over the 45 years I've been in practice is that our understanding of mechanisms and our understanding about the role of the pelvis in function has really evolved and changed. And I think we could all agree that the current main function of the musculoskeletal part of the pelvis is twofold. Number one, it acts as a shock absorber with very little mobility. And I think from my perspective, more importantly, its primary role is to transfer load. And so when we are looking at the clinical application of some of the evidence, the key thing is going to be, how do we identify whether or not what we're asking the person to do in training or in life, when we're restricting what they do, when we're opening it up to anything they can do, how do we know, what tools do we have in our toolbox that measure whether or not what they're doing is, if I could use the word optimal, is good for them, is healthy, is not going to lead them down a road to pain and lack of function. So I think effective load transfer is probably, and when you don't have effective load transfer, all of the different conditions that then arise from it. Because I think what we know from the persistent pain research is that pain is not related to any specific impairment, and that pain is an output. And we can't use either location or behavior of pain to say that that indicates one specific impairment or dysfunction.
Thanks, Diane. So, load transfer is important to you. Um, what that means can be discussed, as well as the fact that looking for one singular impairment can be problematic, particularly in a persistent pain presentation. Adam, did you want to share your thoughts on an SIJ condition problem, as well as anything else you wanted to add there?
Yeah, well, I think the first thing I will do is I think we should start off with an agreement, and I agree with Diane to say that I think the terminology and the wording that we use around the SIJ is a problem, and I think sometimes it leads us to have miscommunication and sometimes misdiagnosis as well. So this term impairments or dysfunctions is often, I think, used interchangeably in between SIJ pain. So I think I like to try to determine the difference between, are we talking about impairments and dysfunctions in terms of, so-called joint immobility, or moving too little, moving too much, moving incorrectly, or are we talking about, it's sensitized, it's irritated, and it's painful as a term as a dysfunction. So I would probably say impairments and dysfunctions. I'll be more inclined to be thinking somebody's talking about a joint moving incorrectly, either too much or too little, and an SI joint pain being something that's sensitized and irritated. And when it comes to causes for that, I think you've got three broad categories of SIJ painful problems. I think we've got pregnancy related SIJ pelvic problems. I think we've got specific pathologies that affect the joint and the pelvic area, such as spondyloarthropathies and those sort of inflammatory conditions. And then I think we've got this third and probably most common cause of sacroiliac joint problems, what I would class as non-specific sacroiliac joint pain, of which there's probably multiple hypotheses and reasons. And this is where I think there is a lot of discussion and debate and disagreement around the causes and the reasons why people have these sensitized and irritated sacroiliac joints. But there are cases out there of people with very much specific problems with the sacroiliac joint. So I think, that's something that we always have to keep an eye out for. Yeah.
Yeah. So the specific issues, the different contexts, so pregnancy, pelvic girdle pain, the rheumatological ones, even things like I've seen car accidents, fractures, and dislocations, like
Trauma. Yeah.
Trauma, right? As well as the fact that if we define impairments as specific to the structure versus pain, which is something different, and the two being different, do appreciate that distinction. And I suppose that leads into that next part, which is, well, then how do we assess somebody who presents with what they've often been told, or they've looked up and seen that they have an SIJ problem? Adam, I'll flip the order back and forth. Can you tell us about the assessment for the function, of the SIJ?
Yeah, sure. So I think this is an area where I will probably sort of disagree. I think a lot with Diane, or Diane might tell me otherwise. She disagrees with me. But when it comes to assessment of impairments of a joint moving around the sacroiliac, or the sacroiliac joint moving too much or too little, then I personally don't know of any tests that are either specific enough, accurate enough, or reliable enough to tell us if the pelvic joint is impaired in its functional ability. So I only tend to use tests that tell me if the SIJ is sensitive or painful when it's stressed or compressed or loaded. So when people talk of impairments, they often are talking about, a joint is moving too much, too little. But I think we just have to recognize that our reliability to judge that is very challenging, because we have no real reference point as to what to base that off. Because human movement around a particular area, around a particular joint, is hugely variable from person to person, and even in the same person, from movement to movement and task to task. So there's all this variability that I think sometimes makes our ability to decide whether something is moving too much, too little, or incorrectly really unreliable. And despite, I think, our best efforts to try and, determine this and assess this with the research and clinical experience, I still think we've got very little idea about what is or is not normal or abnormal movement, from things like foot pronation, knee valgus, anterior pelvic tilts, all these so-called movement impairments, are beginning to be seen as just normal variation that occur in a lot of people without any pain or disability. So yeah, I think I'm a very much believer of trying to move away from classifying joints and movements as being dysfunctional, impaired, and recognize the variation in our movements are extremely common. And I think actually sometimes we demonize movement variation unfairly, and I think sometimes it's actually a beneficial thing. I think there's a lot of time where, apart from certain situations, where movement variation can actually be perfectly normal and natural and essential for our health and function. So I would say, there's that saying, I think I love this saying, movement is life, and that goes for all movement. And that includes the variations of movement. And human movement is an emergent process dictated by so many different variables and factors: individuals' anatomy, their age, the gender, the genetics, their past medical histories, their beliefs, their fears, their experiences. These all influences the movement, the task they're doing, the intensity, the purpose, and an environment that they're moving it in. When we assess people, we often ask them to move in very false environments compared to natural environments that do as well. And all these things will dictate and govern how somebody moves and what we can reliably get information from that. So yeah, I think very much it's a case of me saying that I think optimal dysfunctional movements variable from situation, person to person, all the time. So I think we have to recognize our palpation tests around the sacroiliac joint have been shown again to be very unreliable due to lots of different problems there, variations in bony morphology, thick layers of connective tissue over the joints, making the very small movements that do occur around there very difficult, if not impossible, to detect. And I think the other problem we also have as well is when we assess people, obviously they're in pain. And I think pain is the biggest confounding variable to that movement. And I think sometimes we are, as clinicians, guilty of post hoc reasoning a lot of the time when we assess people with pain. We often see them moving with pain, and then we assume that that movement is what's causing the pain rather than a cause of the pain. And I've been guilty of it as well many times. Seeing somebody move a certain particular way and just jump into the conclusion that aha, we've cracked it. I found out what the problem is. You move in that way, and they're moving that way because it hurts. And as soon as the problem disappears and the pain disappears, they stop moving that way. I really do wish we had that option to being able to have this library or category where we could observe people moving prior to them coming to see us with their problems and their pain. And then we could have a much better idea of, is the way they're moving the same as they were before their pain, or has it changed because of their pain? So again, it's that problem with post-hoc reasoning, implying causation, assuming that what is happening at the moment is the cause of the problem rather than probably just an outcome of the situation. So yeah, when it comes to SIJ assessments or pelvic assessments, again, I just think you just got to be careful about not falling for those fallacies and just being aware again of the research that says the reliability of being able to detect it moving too much, too little, inaccurately or incorrectly. It just isn't there. So I think we are pretty much stuck with the pain provocation tests, and again, I don't think these are perfect either, because as much as we think, that we are stressing and compressing the sacroiliac joint in isolation, we've got to understand there's other factors and other tissues moving as well as we do them, but I think the best cluster we've still got at the moment, despite its limitations, is the Mark Laslik cluster. And I think, his cluster of tests, which I know he's sort of reassessed and now looks at just the 2 painful provocations out of the 4, with the Galston's not being, I never say that name correctly, by the way. The Galston's torsion test is not essential to be used, because you can get the same sort of likelihood ratio around 4.5 if you have 2 of the 4 tests without the Galston's test. So I think for me, that's my sort of go-to assessment process for suspected sacroiliac joint pain. I'll shut up now. I've been talking too long. Sorry.
That's quite all right. There's a lot of stuff in there, Adam, and there's a lot I agree with, but there's one fundamental aspect that I don't, and that's the reliability studies. In the sense that the person I have in my back pocket is Joe Abbott, and Joe is a researcher in the UK who has spent the last 5 years of her PhD investigating all things manual methods, and obviously the reliability studies for the sacroiliac joint come up. And there are a lot of problems with the methods in the reliability studies. And there are, in the last systematic review that was published by clerks, and some really good people were involved in this study, they come up with the same conclusion, that we don't have reliability. But again, the letter to the editor following that publication in 2019, it was just full of things that I don't even understand, which is neither, well, I can't speak for Adam, but for myself, I'm not a researcher in the way that I can actually critique the methods and how things are done. You trust that the methods are accurate. They've been peer reviewed. You trust that they've been reviewed well. And so we look at the inclusion criteria, the subjects, and we jump to the conclusions, because man, when I look at statistics, they just go right over my head. And the trap we fall into is that we trust that they're telling us the truth. And in fact, what Jo has discovered in the course of her PhD is that there are a lot of problems with how the methods of the research being done for a number of different reasons. And that's another podcast for you, Anthony, is to have someone on like Jo, who's a researcher that can actually not tear apart, but break down the literature and help us more to understand it. So my whole take on the pelvis is that the pelvis needs to function like a platform, and whether stable is the right word or not, it needs to be able to mitigate and manage and disperse the forces that reach it in all tasks and activities that we do. And I think the form and force closure theories and motor control theories of the integrated model of function that Andre Vleming and I put together in the late 90s still holds true for me today, because pain does not guide me in terms of how I assess and treat the pelvis. In fact, those tests of Laslitz, and also when you combine it with the active straight leg raise test, for which there's reliability, sensitivity, and specificity for pregnancy-related pelvic girdle pain, and you still have to use your hands in that test. There's manual methods involved in that test as well. They very rarely do I find in my practice 2 out of 4 of those tests positive. And even if they were, there's no indication that it's truly the joint that is causing the peripheral nociception. And if it was, so what? What do I do about it? I don't have a needle that I can inject inside the joint with fluoroscopic guidance that has to be done expertly, according to Bent Sturson. That's not a tool in my toolbox. What do I do about this painful SI joint? It doesn't answer the why question for me. So the load transfer test, as Bent Sturson is now calling it, and in 2002, when Barb Hungerford proposed this test, which she called the Stork test, and basically it's just load the pelvis, stand on one leg, and see what happens at the SI joint. And from the hundreds of studies before it by Vleming and Damon and Schneiders and Baruch, and we could go on forever in the mid-90s, all the work that was done looking at what should happen at the joint. What should happen at that joint when you load it is nothing. It should close pack, it should force close, it should stay stable so that forces can go through it. And the problem is when that doesn't happen. So if you have had damage to the ligaments from trauma or birth, which is not common, if you have changes in your motor control, particularly changes in pelvic floor multifidus relationship, that is, from my perspective, the one of the critical patterns and imbalance that prevents control of the SI joint. That when this happens and you can't effectively transfer load, we get movement at the joint, and it's not about how much. It's not about we're not judging. Is it too much? Is it too little? Is it any? And can we feel it? So in Antwerp in 2019 at the World Congress on Low Back and Pelvic Pain, I was so surprised to see that Bent Sturson had changed his mind about this load transfer test, and that he's using it now pre-surgically to determine who needs surgery, who doesn't, who needs an injection, who doesn't. And I asked him, I went up to him and said, wow, you're actually using the load transfer test. Are you telling me now that you can feel when the SI joint is controlled and when it's not, when it gives way? And he says, no, I can't feel it, Diane. but my physiotherapist can, and I trust them. And I went, and I test them, is what he said. I said, how do you test them? And like you said, Adam, it's the way the pain impacts the motor control. And when he can change the pain in the SI joint or the ligaments and soft tissues around it, the motor control strategy changes. And the physios tell him the load transfer test is negative. So what he admitted is that he hasn't got trained hands enough to feel this. And, the hand in physiotherapists are very much like a violinist. So if you look at the brain mapping of the left hand in a violinist, the brain map for the left hand is huge, whereas the right hand that just does this is not so big. Whereas in a pianist, both hands are well developed. And there hasn't been a study that has looked at brain mapping of the whole hand in physiotherapists who do manual methods, from light touch to listening touch to direct touch, versus a physiotherapist who doesn't train their hands. But the evidence in musicians certainly supports that as your hands develop, you can more reliably start to feel these things. And so Miwako Ishii in Japan has tested this, and her PhD is published in Japanese. So I can only tell you what she tells me. But and it's not just about the tester being better with their hands. There's a certain number of things in the studies that have not been looked at. Number one, what we often see in the reliability studies is that people don't often see what they feel. And I run into this all the time when I'm teaching, where you have two people who disagree on this same test. So what is this test? You're palpating the innominate with one hand, not the psias with your thumb. We have 12 intertester reliability studies that have shown that if you do this and you're just feeling for this, you'll be unreliable. And there's many reasons why. And a lot of the answers come from the robotics research when they're building prostheses for the hands. And the thumb is the spatial orientator. It doesn't have the same receptors in it as the palm, as the index and the middle finger. And this is part of sort of Joe's journey as well, in terms of looking at why are people seem to be more reliable when they use their whole hand versus just a digit. So when we change that and we have people getting information from multiple parts of their hand, their reliability, and this is all empirical, Adam, none of it's been tested yet. Well, Joe's tested it, but it's not published yet. Absolutely goes through the roof. And the other thing we found is that if you have something happening in your shoulder girdle, where when you put your arms out like this, you're rotating for whatever reason. I'm not judging that that is a good thing or a bad thing. It just is a thing. And if you are then looking at the pelvis to see where it is in space, and you have one arm that's apparently longer than the other, you will feel that pelvis rotated to the right in every individual that you assess, unless your cranium and your upper neck is rotated to the left. Because our nervous system takes in information from what we see, what we feel, our biases, how we stand, how our own body is. We often use interoception to know where somebody else is in relationship to us. And those testers are incredibly unreliable because they see things differently than they feel. So Joe did a study, 256 manual clinicians of multiple different disciplines to test that hypothesis. And when she pulled the data out of the study of the people who had incongruent rotations in themselves, were twisted in themselves, the reliability just went through the roof. So there's going to be some really interesting data that I'm sure people are going to debate and go on with that gives us a better understanding as to why we haven't shown reliability. If you stand on one side of somebody and you tilt your head this way and then you tilt your head the other, your thumbs can be seen to go up and down. So there are all sorts of things about the testers that actually haven't been tested. So it leaves us with, okay, the evidence shows and supports that the pelvis has to transfer load. Pain is not a player here. It doesn't always tell us when the function is what it should be, and that there should be no movement, at least no movement that we can feel when you're transferring load. So how do we pick up those people where they don't have good motor control strategies? They don't have good force closure mechanisms. They can't hug and hold the pelvis together when they stand on one leg or they do a squat. And so at the moment, the best test we have is the load transfer test, where you feel the whole innominate, you feel the sacrum with as much of your hand as you can, not just your thumbs, and you feel for any giving way or movement, which the common ones anterior rotation, but it isn't the only one. But then we need further tests to say why. Does it matter? Is it really the pelvis that's the problem? Or are there things going on elsewhere in the body that are loading the pelvis so much that its motor control strategies are insufficient to keep the platform stable? And so again, this speaks to your point, Adam, about we can't just say because the foot is pronated or the hips anterior, or you've got thoracic rings that are rotated, that that's a problem for someone. But we can develop tests and offer changes or suggestions to how somebody is standing on their foot, placing their knee, changing their hip, changing something. And then we can further test, almost like a Maitland test, do, retest, test, and then retest to see what does that do to the patient's experience? Because what we're trying to change here is the patient's experience in their body, where they feel better balance, more on their foot, stronger, more efficient movement. And yes, over time, my experience is being pain, nociceptive pain anyway, will change when you improve function. And I think on this is where Adam and I are really going to agree that if we can increase people's functional levels, that a lot of nociceptive pain will take care of itself. And I think as we go further down the path in terms of how do we determine how much we can load people and how much we can ask them to do are going to be very different trajectories. But our goal in the end is going to be the same. Get people doing more, stronger, fitter, much more functional, and then the pain will take care of itself without it actually directly being treated.
Thank you, Diane. I'm holding my pen up just to indicate when, stuff, when the time, trying to keep the time thing going. There's a lot there to unpack. If I could just quickly summarize what I heard, there's an issue with reliability studies. There's an area to investigate in terms of, well, what if we looked at the baseline, I suppose, for each of the testers in the studies. That brings up the question of how do you test that reliably in and of itself. And then, you've emphasized that load transfer is important. You mentioned Sturrison as well as being able to feel that something isn't quite right. So am I okay to just summarize that by saying physios can feel a coordination pattern, a motor control change, and perhaps that's what we're feeling, because that's what the load transfer test is, a coordination test, and I do want to hear from Adam as well. So hopefully, there's a lot that you...
One sentence. We can feel the impact of a motor control change. Yeah. We can't feel the motor control change, but the impact on what's happening on one side of the pelvis, yes, we can feel.
Yeah, thank you.
Adam? Just say something. I find that very interesting with regards to the reliability studies about how palpation could be improved with training and improved tactile sensory information in our nervous system. I find all that stuff very, very fascinating, and I no doubt it is a skill that can be trained and adapted and improved, absolutely, but it still doesn't take away from the fact that we are palpating a variable human being in a variable situation. So again, although we may be able to improve our skills of palpation, our ability to be able to interpret what that actually bloody means is still very unreliable, because again, we don't know what is normal or abnormal. We haven't got any reference points. We haven't got any basis to say, if it does move, is that movement too much, too little? Is it okay? Is it wrong? It's based on so many different contextual variables. And the other thing I also agree with is the fact that, and I thought this was coming on to the next question about, what do we do with our information from the assessment? And what I like to do, and I think you were alluding to this as well, Diane, is do these little movement experiments, do these little testing procedures that with somebody that you suspect has got some sacroiliac joint issues, whether that's the pain or something else that you're thinking, and often doing some simple movement-based tests based on normally on what the patient has told me is an aggravating or fearful task or activity, and seeing how their pain behaves. and seeing it whether it is able to be changed or modified, I think is essential for our experiments, our tests and retests, and being able to see whether we can change somebody's painful experience by asking them to do, whether it's a single leg stand, whether it is being able to do something a little bit differently in a different rotation, slightly different foot position. I've done some weird and wonderful things, as I'm sure you have done, and found it's modified pain. I've had people just gripping their hands harder as they do a painful forward flexion movement. And that can sometimes modulate and modify their painful sensations. I've had people clenching their teeth and doing the same thing. So there's all these weird and wonderful ways that you can sometimes, play around with movement experiments. What it doesn't do is it doesn't tell us that the harder questions to answer. It doesn't tell us why or how these things did change somebody's experience of pain. Yes, one of the theories is it could be improving force closure. It could be improving some biomechanical aspect. But there's also other explanations as well around it. So I think we've got some agreement here with regards to, what do we do? And I do think that, is good, but I do think it's the explanations we're using and the sort of theories we're coming up with as to how what we're doing is doing what it is doing.
Yeah, 100% agreement on that. 100% agreement, Adam. And I think that as we learn more about the pelvis, we learn more about what we don't know. Like, you don't know what you don't know until you know you don't know it. And when we try to explain how things work, because patients, they get comfort in knowing, what do you think is going on? Like, this whole thing is serious, isn't it? Something's really bad is wrong with me. Like, I need another MRI, right? And we go down the whole, not the rabbit hole, because that's going the wrong way, but we go in the journey of not catastrophizing things. And so you try to come up with some kind of explanation that is less serious. And I think this is where, as clinicians, we might get into trouble using words like loose and stiff. And I don't think most of us use out anymore. And I would agree with you, if a clinician said to a patient, oh, your joint is out, that you need to run away, because that really needs to be another whole other conversation. But things like loose and stiff in and around the sacroiliac joint, I think, are very valid terms in context of the whole story, in terms of when you hear what's happened to them, when you put a cluster of your tests together. And I often use the finger test, where I say to people, every joint in the body has a very small amount of movement. And that amount of movement facilitates in some joints larger movement, and others not much at all. And therefore, it needs to be controlled. But if you're not controlling that movement well, it can create microtrauma. And that's the word that Bent Sturson has used in his latest article and update on the SI joint, is this idiopathic, non-specific microtrauma of the SI joint. And so loose can be used loosely, in the sense that when you use the word loose with the patient, you need to really further explain, what do you mean by that? Do you mean that there's been loss of ligamentous integrity? Is the pubic symphysis got a big 2.5 centimeter diastasis from forceps delivery? Has there been a fracture? Are we talking about like a loose joint in that way, which is extremely rare, but not uncommon? And most of the literature for that, Jerry Hesch reminds me, is in the trauma literature. It's not in the physio literature. And then we have the more common one, which is the motor control changes, where the muscles aren't working like an orchestra. And we know from the back pain research that people's strategies in pain are highly variable. No two people do the same thing when they have back pain, in terms of which muscles turn up, which muscles become inhibited. It's all over the map and different, which is why any RCT which tries to measure efficacy of clinical practice, and it begins with pain. We took a group of people with pelvic girdle pain. We took a group of people with low back pain, and we applied this one intervention, is always going to fail, because we don't have homogenous groups of people in pain. Everyone is an individual. And so this is where I disagree a bit in terms of the ranking of evidence, and that a case report, although filled with bias, has no value, because I really see my patients in case reports, and I don't see my patients at all in any RCTs I read. because we treat Mr. and Mrs. and Ms. individual. We don't treat the average or the mean. We treat the outliers. We treat the patients that are excluded from all of these studies because they got too many comorbidities. Well, I'm sorry. The person who has the ankle sprain and then a couple of babies and then gets a whiplash driving their son to hockey and so has neck problems, pelvic floor problems, and a sprained ankle, I don't see that person represented in the literature at all. And so, where I agree with you strongly, Adam, is that we have no idea what the relationship is between these impairments until we test them, until we see a foot and we look at it and we kind of go, I wonder if the behavior of this pelvis would be different if I could train the foot or support the foot or change this loading pattern through the foot. So rather than just wonder, we just test it. We just test it. So support it, change it, tape it, do something, use a verbal cue, use your hands. And then it's not our judgment of, like, if I go to the pelvis and use the test I love, which is the Stork test, and go, oh, your pelvic control is back. You must be better. No, not good enough. Not good enough. What has to improve is the patient's experience. And whether it's a reduction in pain, as you mentioned, Adam, or whether it's just an improvement in performance. And I ask them, how does this feel for you? What do you feel? And I use their language. They may say, well, I feel more stable, or I feel more, I can find my foot, or I feel whatever they feel. And then I won't judge that either. I'll then say, and is that a good thing for you? Is that something that you would then say that feels better, worse, or no change? I'm always saying better, worse, no change. And it's their nervous system that then judges and interprets where we're going to go. And so then we don't have to worry about, is this posture bad? Is this type of movement bad or good? The patient decides, right? The client decides, in the sense of if it feels good and feels right, then let's go down this path, regardless of what muscles are working, what order they're coming on. So the patient's experience is really, really, really what guides it. But the test, retest, and the offering of change, and not treating the pelvis in a silo, not looking at the pelvis as it's separate from anything else. It is part of an integrated system everywhere. So you have to have tools to assess and treat the foot, the shoulder, the neck, the thorax. Otherwise, there's going to be a certain number of people that just, well, they won't get as better as they could if you could treat all that and assess all that.
Okay, thank you for that, Diane. It's a very interesting thing, and both of you have raised that there are issues with the assessment, as well as with using the results, the post hoc fallacy, using the results to, prove theories can be an issue in terms of also, both of you have shared a concern of how that messaging can affect the client at the end of the day. And that's really where this third section of this discussion will go, is about that. And one of my questions, and one that lots of people have asked me, is, do these words that we use to describe what we feel or to describe what we think is happening, do they have an impact on where things are going? So Adam, I do want to throw to you. I have been keeping track. So you've got 6 extra minutes so far, Adam, around that. So
okay, well, I didn't know we'll be in that I didn't know we'll be in that closely monitored. I'll keep an eye. So again, just
got extra.
Okay. Well, just to say that there are, again, when Diane was speaking, I've made a few notes. There are things there that I absolutely do agree with, and there are things that I don't with. And a couple of things to say to start off with that I agree with is, when Diane talks about the fact that the pelvis is integrated and we shouldn't be assessing it on its own, I absolutely agree with that. But I also say pain is also integrated and shouldn't be assessed or considered to be solely due to one individual factor as well. And again, I can't have a talk without saying, we're talking a lot about the mechanics and the muscles and the force closure, but we've also got to recognize pain is a multi-dimensional experience, and we also got to look at the person and their lifestyle and their behaviors and social economical backgrounds around their mechanics as well as a causative factor. And sometimes, it's these things that I think we sometimes overlook, or we don't have the time to fully get into because we are focusing too much on the mechanics. And that's not to say, before anybody starts screaming at me out there, that the biomechanics are not important, or we shouldn't assess people and all that sort of claptrap and false dichotomies that they throw at me. They are, but I just think we've got to find that balance of trying to look at the person as a whole, their lifestyle, their background, as well as obviously what's going on in the area of pain and their biomechanics. And the other thing I think that I also agree with is what Diane was talking about was, we need more case studies. I absolutely agree. Case studies are, I think, really, really useful in the research, and they are sometimes looked down on and belittled, and I think completely unfairly, and they can be very useful. But what I think is even more useful than case studies is qualitative studies based on patients' feedback and experiences of what they experience going through the healthcare systems and being assessed and seen by us therapists as well. And we get some really useful insights here about some of the harms and the helps that we do as therapists. And one of them is the explanations we give to patients. The words we use very much can help, but also harm people. And again, trying to determine what are the best ways of explaining things is, again, I probably think, we're not going to find one rule fits for everybody. We're going to find that, everybody has a different understanding and interpretation of the words and the terms that we use. So I think it's more, not so much the words, it's so much that it's more the understanding of what those mean to somebody that's more important. But I very much do not like using the word loose around the pelvis. I very much find that can sometimes be very much misinterpreted and misunderstood. When people are trying to understand their pain and why they've got the discomfort in the sacroiliac joint, I much prefer to use terms like irritated, sensitized, hot spots, and all these sort of things, and try to manage the uncertainty of trying to really label a particular cause or reason in something that is multi-causal, that is something in multifactorial. So I very much do not try to blame looseness. Weakness is another one as well that I've moved away from. And I find this very challenging because it used to be my sort of go-to get out little easy scapegoat. I was going around very many years ago telling everybody I saw, you're weak, you need to get stronger. You need to get stronger. If you don't do your exercises, you're never going to get out of pain. And, I look back and I cringe and I feel awkward at that now, because I now know that's not true. And it is still quite challenging for me to accept that actually, we don't have to get people stronger for their pain to be improved. We need to probably get people robuster. We need to get people more resilient, but actually their force output, their strength sometimes doesn't need to change. Now, don't get me wrong, I don't think there's much harm in getting people stronger. I just think it's not the only reason why people get out of pain these days. And that's very hard for me to admit and accept. But, I very much do think, when it comes to, language and terms and explanations, we are treading, it's almost like walking through a minefield. Something innocuous that somebody else has absolutely no issue with sometimes can absolutely put the fear of God and anxiety into somebody else. And sometimes we're completely unaware of that situation. We're completely, we don't say these things with any malice or malintention. We do it the exact opposite to try and help people, but we just don't realize sometimes that we're not, and we're making things worse. And so I think, we just got to listen to what patients tell us. The feedback from our failures is absolutely essential. And there are many people out there that I've come across on social media who are patient advocates who have been failed by a physiotherapist, who have been given some bloody awful explanations and managements of their problems. And these individuals are really helpful and useful for us to try and guide us and give us some way forward in trying to tiptoe through this very awkward and difficult minefield of education and explanation.
Yeah.
100% agree.
Well,
100%.
sorry,
100%.
Diane, I don't mean to cut you off. I just wanted to ask a quick follow-up question for Adam, and in terms of the summary. Thank you for what you said. in terms of the explanations, the looseness, the weakness, what we used to do, one of the things that seems to be out there is that we can point the finger and say what's a lot wrong with the profession in the explanations and the words we're using. And it feels like there needs to be a new vocabulary provided for people, an explanation and examples, I suppose. What are some of the ways, if somebody presented and said that my therapist said that I have probably some of the words that Diane had said, and I'll give Diane a chance to say similar things, and they came to you and it happened to be unhelpful, because sometimes for them that might be helpful. What are some of the ways that you've reframed how you've said it to minimize the impact of those words? Adam.
It's a very difficult question to answer, because again, I find it really depends on what the person's understanding of those words mean. So if they said that, I've been told I've got a loose pelvis, and I was like, okay, what does that mean to you? Well, I think that every time I take a step, I'm getting this happening, and that's causing micro trauma, and that's causing damage, and that's causing harm to my joints, and therefore I don't want to walk around anymore because I feel like I'm going to do things and make it worse. So again, a word in isolation probably, it doesn't tell you much. It's the meaning, their understanding of what that word means to them. So, and other people, you can say, I've been told I've got a loose pelvis. What does that mean to you? Means I need to do my bloody exercises and get everything tightened up. I'm like, okay, is there much harm in that? No, that's good. And have you been doing your exercises? Yeah, absolutely. I want to get this sorted out. That's a positive experience of that word of loose to a certain degree. What I don't want them to do is then go away and think they've continuously only got to keep doing these exercises forever and ever. I mean, again, no harm in doing that, but I don't want them to have that misbelief about how essential and necessary it is to keep doing this to prevent further problems on down the line. Because again, I just don't think we've got the evidence to say that that happens or not. So 2 examples there, and again, using the same word, 2 different experiences of that.
Yeah, and that ability to meet the person where they're at. Both of you have said that you're meeting them where they're at. You're using their language. You're helping to make a more accurate, reasonable explanation. Is how I take it from both of you. So, I think that's the biggest area of where we need to continue to change and do different things. And so, Diane, on that management side of things, as well as to what Adam said, what are your thoughts there?
Yeah, I don't have anything to add with that. I must admit that I don't use the word loose that often anymore. It's more about control, and can you control and manage the loads in your body, and and totally agree. People use language in many different ways. But if we go, I'd like to go further in the time that we have left, and Anthony, I think this is where you're going to talk about is specific muscle training necessary? So, for example, I've had this question all along. I wanted to ask Adam if I can. How do you assess the pelvic floor, Adam? What tools do you use to assess the pelvic floor? Like, there's lots of evidence that shows that, particularly in the pregnancy-related pelvic girdle pain group, that avulsions of pubal rectalis and pubococcygeus are common. 30% of women in a first vaginal delivery have some trauma or tear, and it's a muscle that's not surgically repairable. Which is going to change the whole force closure mechanism in and around the pelvis. For the longest time, until I actually did some internal pelvic floor courses myself and then started working with ultrasound, I didn't have any tools in my toolbox to assess the pelvic floor. I was a TA multifidus glutes gal around the pelvis. This empty bucket thing, it's something that musculoskeletal therapists are asked all the time. How do you assess the pelvic floor? How do you know if the strategies the person is doing is supporting pelvic organs? I'll stop there. I'm curious to hear how you involve the pelvic floor in treatment of the pelvis, pregnancy-related pelvic pain.
Yeah, it's a great question, Diane, and I'll answer it quite simply, is that I don't, and I pass them over to my pelvic health specialist who takes over that population for me. So I do not see any pelvic pain patients due to pregnancy or postpartum. That's definitely a a area that I am lacking any type of assessment, knowledge, skills in completely. So I will put my hands up here and say that's definitely not an area or field I work with.
And we don't have to have tools in the toolbox for everything, but we have to know when to refer. So
Yeah.
what is there a test or something in the story, or what is it that says, okay,
It's
I
the
know.
population, basically. So if I'm seeing a pregnancy-related suspected sacroiliac joint pain, that population is most likely to have some form of involvement of some perhaps internal pelvic floor type contribution to their factors. So I will then very much refer on to the specialist who would deal with that.
Okay. And multifidus? Any tools?
Yes, that again is a muscle that I think has been overused and overdiagnosed. So I think it can't be individually assessed. I don't think it's a muscle that can be isolated very well, and I don't think it needs to be isolated very well. I know, again, I am going to be probably disagreeing with a lot of people out there, but I think we focus a lot too much on that. And again, when it comes to isolating exercises, I am very much a fan of moving away from that and making exercises more global and functional, rather than actually sitting down and doing the stability exercise. Because again, I've realized and I've researched there's no specific benefit of doing these stabilization exercises. I won't say they don't help, because they do, but I don't think they have any superiority over and above general or generic exercises. And my bias and my preference is to use general and generic exercises rather than specific stabilizing ones.
And I would agree with you that our goal is not to train muscles in isolation, because everything is an orchestra and it's in harmony. But I mean, I think some of the work that Julie Hides, David McDonald, Laura Mimosa years ago did in identifying, and then Paul Hodges recently, in terms of looking at what happens to these small muscles, and more so in the lumbar spine than they have in the pelvis. The pelvis hasn't received the same amount of research as the low back and the neck have. In terms of what happens both in the acute phase and in the chronic phase. And again, we don't know the mechanisms as to why. Why does the brain all of a sudden reflexly inhibit this muscle in the presence of pain? And why doesn't the brain, once the soft tissue injury is healed, why doesn't the brain bring it back if it's that important? Why do we need it in the first place? We don't have the answers to those questions. But I'm not sure if you're familiar with this studies, but one of the latest studies, 2014, I think Julie Hides did, was looking at the Aussie Rules Football Club. And they were able to predict, based on capacity and size of the lumbar multifidus, who was going to get a lower extremity injury, either groin or hamstring strain, that year, based on capacity and size of multifidus. So much so that they totally changed their training in that football club to actually make sure that multifidus was included. And they use ultrasound to test, but I again use my hands in terms of, like, when you test a quad, Adam, and you look at it, you see the size of it, you can feel the texture in it. There's a whole bunch of different tests, some of which are manual, some of which are a tape measure, some of which are just looking at performance. But there's a cluster of tests that tell you, is this muscle healthy enough to perform the task that it needs to do? And multifidus is really no different. And is it integrated and working well with the other muscles that actually force close the pelvis? And for me, so many patients that have failed in general exercise global program. So I see two subgroups of people who do well with yoga, Pilates, and gym training, no matter what it is, as long as they're moving, training, loading, they do well. And there's a subgroup of people who don't. They just keep either getting injured or they keep getting hurt. And often those people, when they start to load or you change strategies, they don't find better strategies or ways to load in their body. And this specific training for a short period of time, talking no more than four, sometimes 6 weeks, is for me the missing piece in the rehab. And that when they can bring these small, deep muscles back into the whole orchestra, if you like. So they're not any more important than any other ones. They're all really important. But when you can bring them back in, you can see persistent, long-standing pain and function limitations really, really change. And I'm happy to share some of that research with you afterwards. If you like, um, yeah, I feel pretty strongly about this multifidus.
Can I just ask what the exercises are that work these deep isolated muscles? What are the types of
It
exercises
doesn't
that they
matter
do?
about the exercise. It's the piece before the exercise. It's reconnecting the mind and the body. It's making
So
sure.
so what is the task or the movement that does
Right.
that?
So it's usually a leg loading task. So either they're lying in hook lying and an active bent leg raise, not a straight leg raise. So this is the test, okay? The test. So they're laying on their back, their knees are bent, lift one foot up, lift the other. Does one leg feel heavier or harder to lift? Meanwhile, I am palpating over the base of the sacrum. And what you feel when you feel a multifidus that has atrophy and hasn't been used for a while, it feels like a flat tire. So you feel the thoracolumbar fascia, the tension in the fascia, but you can push the fascia in. There isn't that bicycle air in the tire resistance. There's no capacity in the muscle. If there's fatty infiltration in it, it feels almost like an avocado that you would pick for guacamole and not one that you would pick for salad. And that's the best way that I can describe what it feels like. Okay. So then it often co-activates with psoas. So if you give the person we call it a connect cue, but if you think about a guy wire or a line where you're hugging the femoral head towards the sacrum at the back, like a puppet. Imagine you're lying on the table and you're just preparing to move, just engage. And all sorts of different muscles will come on. I'm not so worried about what other ones come on at the moment. What I want to feel is a swelling or a contraction or a pumping up of air in that tire. But more importantly than that, I want them to hold that and now load again, lift the leg. They have to have a change in experience, right? They have to have the leg, you can witness it, you can see it when it's done. I don't like the words well or properly, but you know what I'm trying to say. When it's different and more effective, the leg pops up, they go, oh, that feels easier, it feels lighter. So it's more efficacy of loading. If you don't have that piece, then it doesn't matter what they do when they go home. They're going to stay with the same strategy. So they have to be able to perceive a difference in effort and in loading with doing things one way or the other. And they will often come back and say to you, that's really hard on my brain. And I go, yep, because that's exactly what you're training. You're training the nervous system and the motor map. And it's more neuro in nature. Because you can't strengthen a muscle the brain isn't using or the nervous system isn't using. So if you want to bring this muscle back in and you believe that this muscle, I do anyway, is what connects the left and right anominats together in addition to the glutes, but it's the deep connection, it and the pelvic floor. And that when you can effectively co-activate the pelvic floor and multifidus, you can force close that SI joint so that at least they can sit. At least they can go from sit to stand. They're not going to be able to load so much without more training and integration of the bigger muscles that are important. But it's the place for the severely traumatized postpartum pelvis that I think is where, for a subgroup of people, we really, really need to start. And I think we have lots of evidence in the motor control world that this is really critical for not just pregnancy-related pelvic girdle pain, but for people who have had a disc injury, injury to the sacroiliac joint that's ultimately led to reflex inhibition and then atrophy of the deep fibers of multifidus.
Can I just say a few things, Anthony, on that?
Oh yeah, I'm waiting. And if anyone's confused by my expressions, I'm reading 2 sets of comments and all sorts of stuff. So
I think this may be where we need a part 2, because I think there's so much more to explore here with these discussions around the specificity of exercises and the integration of the mind muscle connection, getting the nervous system to integrate. So I mean there's a couple of things there that Diane was talking about that made my eyebrows raised about how, you know, you can't get a muscle to work if you don't have the mind connection. And I'm like, the only reason a muscle isn't going to work is if you've got a neurological disease, or you've got a neurological trauma that's meaning that there is a break in the connection between the muscle and the central nervous system. I would say, yes, using thoughts and using isolation type movements are more likely to make a muscle work differently, and you may ask it to do, or you may see it improve its force output and its capacity, but that doesn't mean it's the only time it will do that as well. So I do think, again, it's these common assumptions that certain type of exercises outperform other ones because of specificity and connection that I just very much disagree with. And I don't think there's much robust evidence that proves that. And again, I'm not going to try and say that I don't think any of these lower intensity floor-based motor control exercises, I'm using air quotes, I know I shouldn't do, it's a bit facetious, but these sort of stability exercises, I'm not saying they aren't useful for certain populations. I think they're very beneficial. I think they can be really useful for, as Diane says, the severe type of cases with, lots of weaknesses, lots of fears, lots of anxieties, lots of pain, lots of sensitivity. They can be a nice introduction to help people move and feel safe and secure, and start to make their movements feel easier and lighter, and all these words that Diane was using. I just don't think they work the way we think they work. I just think they are lower intensity movements that are done in an environment that makes people feel safe and secure. And I don't think, as I say, giving people all these informations or cues or tasks is necessary or needed a lot of the time. And I also think the explanations around them as well, again, potentially could be detrimental and harmful to some people in thinking that they've got some sort of impairments, or they're moving inaccurately and incorrectly, that can then follow them on for longer than we'd probably want them to.
Thank you, Adam.
I prefer deadlifts.
That's not a
I'll send you
secret.
some evidence. I'll send you some evidence, Adam. And here there's evidence.
I do want to point out that we have hit the hour, and there have been calls for a part 2, because there are more. Well, we've only just scratched the surface, and you both have such great things to say, both of you. And if I could have the unenviable task of summarizing just some of the recent stuff, as well as the what's going on, and I'll give you a chance to have some last words, both of you, of course. I was hearing that Adam, your population, you refer, it sounds like you very much have the attitude of I know what I'm good at, I know who I'm good at working with, and if somebody else is better at working with that, then I will refer on. And Diane had a good question about, well, how do you know when to refer on? And there are screening questionnaires and things like that. But I think that shows, I suppose, expertise. You know what you're good at, you know when to refer on, and I think that's something we all need to do. The population who needs something different. That was my summary of what you were saying, Diane, including the multifidus stuff. That queuing before a task, there would be indicated that it is helpful. Like Adam said, it is helpful for some people, maybe not as many people as we think. And what I'm getting from both of you is that meeting the person where they're at and finding the things that are helpful for them is important. The phrase that I just wrote down, Adam, that you said was a lot of the time. So it's not a never, it's not a hard no. There's a lot of nuance, and there's actually a lot of comments about thanking both of you for this discussion and being able to hear your thoughts. So what it comes down to, my takeaways are that, even for the multifidus thing, it seems like when you do a specific activation cue, you can, and using the multifidus as a barometer, you can seem to make changes which seem to correlate to predicting injury, lower limb injury, you said, Diane. You know, we can put our hands on and feel things, but what does that mean? And ultimately, how does that affect the person and the meanings that we put around it? Are we confirming our theories, or are we trying to find a useful way to help them? And both of you have both acknowledged that helping people, whether they've got pain and symptoms or performance enhancement, I know both of you help people to improve their performance as well. You know, that ability to help people achieve that goal and what that looks like is different for each person that you meet. So any last words in, you know, somebody might watch this, they're not a therapist, they're not a fitness professional, they're not in the industry, but they've got pain and dysfunction. Any last words about a message that you would give to them about what they might hear out there in the wider world, and how you might want to leave them with a message, I guess, of hope? That's a bit leading, but I think both of you want to give hope to people. We'll start with you, Diane.
Oh, wow, big question. I think what I would like to say to anybody who is experiencing pelvic girdle pain is don't give up. That there is ways forward, no matter whatever kind of pain that you're experiencing, and that if you are not feeling satisfaction with the practitioner that you're working with, and here I agree with you, Adam, go find someone else. Go find someone else that you resonate with, that you can work with, that makes sense to you, and that can self-empower you to understand maybe a little bit more what's going on in your body, and find strategies and ways to move forward that actually meet your goals. Because we exist, and there's good and bad in everything, or there's just differences in ways that different people do it. And there's a lot of us that are here for you. So keep searching.
Adam?
Yeah, great comments, and I'll just reiterate pretty much what Diane said there. I think it's a great summary to say, you know, finding the right patient therapist fit is the key to success. And again, if you have got pain in your back, in your low back, or in your very low back, or wherever you are feeling it, again, be optimistic that these things do have favorable natural histories, and that, you know, finding a good therapist to support and guide you and promote and facilitate you through this process to get the best outcomes possible is key. And again, you know, just try to be optimistic and hopeful about that, and try not to worry too much about things you may read or may hear about, you know, the causes or the explanations around it, because there is a lot of uncertainty about why we have pain. We are taking at best educated guesses, but that doesn't mean it's 100% correct or accurate. And there are lots of ways and means of reducing and removing pain, and it doesn't always mean that you're moving incorrectly, or you're broken, or you're damaged. It's sometimes the case that things are just sensitive and irritated because of multiple factors going on in your life at this current situation at this time. And often it's about giving those things time to settle and reduce, but also trying to develop a more comprehensive capacity, robustness, and resilience in you as a human being, to restore painless, fearless, thoughtless movement, which is always our ultimate goal. God rest Louis Gifford's soul for that saying as well.
Thank you both for a wonderful discussion. You know, I'm sure that lots of people thought that it was going to be a bit of a yelling match, and you know,
to be honest, so did I.
I think it's been a fantastic discussion. I think that you know, the respect that you've shown each other to be able to agree to disagree, I think it proves it proves again, despite the possible post-hoc fallacy, that conversations in person are so much better than across a keyboard. You know, communication is so much more than just the literal words being said. So thank you both for a fantastic discussion. I am looking forward to other things that we can do together. And one thing that I heard from both of you is, if something is not working, do something different. If the person isn't jiving with you, find a different person. And you know, for the person who is receiving messages, if it makes you full of fear, and you know, I think both of you have this. If a message induces fear in you, then I think asking that therapist to perhaps word it in different ways, or at least let them know, is such a helpful thing to do. Because as you can see, two very different clinicians who share so many common points ultimately want to help you feel empowered to achieve your goals, move out of pain and into functional activity that you want to do. I think that that would be one of the best things that we could do to help people. So thank you very much. Now, there are questions about getting access to some of the references and things like that. And I'll talk with Diane and Adam about that, and I'll make sure that you have ways to access this. So keep an eye on this account, as well as please follow Diane and please follow Adam. And, I'm sure everybody joins me in thanking you both very much for today.
Thank you, Anthony. And I'd just like to thank Diane as well for her time. It's been enjoyable finally meeting and talking. So thanks very much, Diane, for your time. I've enjoyed it. Thanks, Anthony, as well.
I'll have to get together when I'm in the UK next. It could be fun. I'll bring my ultrasound unit. You can show me some things about multifidus, and I'll teach you how to assess the pelvic floor on ultrasound.
We can go and do some deadlifts and have a glass of whiskey afterwards as well. That sounds like
I like that idea. That sounds good. Okay. Thanks, Anthony.
Thank you. You're both class acts. Thank you very much, and we'll see everybody later. Thank you.